Okay. All right. So Travis, do I need to, under share screen, do anything to bring myself up?
You should just be able to select share screen, and if you do your full screen, that's probably easiest, and then you can toggle to any of the documents or apps you want to go to.
Okay, so I hit share screen, advanced sharing options. Uh, if it doesn't work, it doesn't work. That's all right. Um, we are going to start because what I'll tell you ahead of time is that for the next couple of months, and the very first thing, and Travis, I'm going to trust you to be the judge on this. I've got a question, and other than for, and this is unfair, because other than for the Vivage Beacon medical directors, I've got a prize for whoever puts the answer in the chat first, and we'll give the answer before the meeting's over. So the question, what do Premarin, antiarrhythmics, and aspirin all three have in common? And with that said, we will get started. I apologize ahead of time for sending out so many attachments, but because we're just going to try to cover a lot of things in a short period of time, I wanted to get them all out there. First thing I want to do is talk about RSV vaccine, just to get everybody on the same page. It is approved. It should be available 4 to 6 weeks in the next couple months anyway. It is, for us in nursing homes, one of the things to know, it's not terribly expensive, but it's not cheap. So it's, I think, a couple $100, $300 maybe. If you have a Medicaid population, Medicaid will pay for it, but it doesn't mean you send them the bill. So what happens is the facility has to provide it. They have to pay for it up front, and then 60, 90, 120 days down the road, they'll get paid back. So it's like giving the federal government a loan. So they're probably not going to be able to do everybody at once. Things that are different about it, it's only available for people over age 60. You're supposed to do shared decision making, which means you're supposed to sit down and talk to them about why they want it. It would be nice for you to know why they'd want it. It is, if you were here last December, you saw that we had it in epidemic numbers in our facilities. Only time in my career that I've seen 3 different respiratory viruses all peak at essentially the same time. So we had flu, COVID, and RSV all in December. It is worthwhile. You can talk about it. The main issues with the side effects would be local, typical for any vaccine, local pain, redness, swelling, maybe mild respiratory symptoms, 24 to 48 hours. And that's about it. It's about 84 to 86% effective. There are 2 different vaccines, one by GlaxoSmithKline, one by Pfizer. The only difference is the GlaxoSmithKline is an adjuvant vaccine. So it has adjuvant in with the antigen that's supposed to help it work better. In the clinical trials, it was essentially identical with or without the adjuvant. It's a good thing. It primarily hits kids under age 2 are the primary target, and it's often lethal in that age group. Our folks, it's becoming more and more common. One of the other problems, even if somebody's never had asthma, as much as 30% of people that have RSV, even adults like us that have RSV and get over it, will have reactive airway disease that may last for weeks, months, or it's not unusual for it to last forever, sort of a permanent thing. So if you can prevent that, it's a good thing. Anyway, RSV vaccine available soon. 2 choices. You have to order it, and facility will probably do it in batches, month to month. Second is just a quick update on influenza. I included one article about early influenza this year in Australia. The Southern Hemisphere always gets the year's flu before we do. That isn't necessarily indicative of it getting here early, but it might. I would tell you, again, of the 4 strains in the vaccine, the H3N2 is the one we're concerned about. There's almost none reported through the CDC so far. I'll keep a close eye on that. Facilities should have their vaccine by now. I've been telling facilities, go ahead in the next 4 to 6 weeks, get your staff vaccinated, because the vaccine is going to be good for a year easily. For our patients, those who are sick, and especially the older they are, it just isn't going to last that long. At 90 days, only 25% of people still have, over age 70, still have protective antibodies. So my preference for patients, if it's a normal season, we're not going to see flu A until mid-January to February. So I tell people wait till mid-November to mid-December. Anytime in that gap would be when I would want to vaccinate residents, unless there are indications that we're going to have an early flu season. And in Colorado, we're pretty lucky because Texas, California, Florida, Hawaii always get flu before we do. And there's usually 2 weeks between when they start seeing peaks and when we start seeing it. So if it comes early, like it did last year, we have time to respond quickly. COVID vaccine, I will send out another article today that I just pulled out today, showing that the expectation is this Friday, the new COVID bivalent vaccine should be fully approved. It is, I mean, you know, who can say what to do with COVID vaccine these days? For those of us that want to get the vaccines whenever they're ready, it's a good vaccine. For myself, I'm going to wait until there is a variant of concern, which will probably be from India, South Africa, Brazil, somewhere else. We should have about 6 weeks head start to say, there's a new, like the BA286 looked like it was going to be terrible, but it just hasn't turned out to be that bad. I'm going to try to time my own COVID vaccine about 6 weeks before I think something bad is out there. Okay, that's COVID. Anything about vaccines before I go on to the next set of topics? Okay, then I have one more vaccine to talk about. As I've been reviewing charts in the past couple of months, I still see a whole bunch of charts that have as standing orders. Go look for Pneumovax and Prevnar 13. If you see that in any of your facilities, get rid of it. Quit doing that. The only thing we're really interested in at this point in time for pneumococcal is Prevnar 15 or Prevnar 20. And the biggest difference is if you give Prevnar 20 for now until we get a new set of strains that dominate. But if you give Prevnar 20, you're done. They're done. That's all the pneumococcal vaccine they need. If you give Prevnar 15, then a year and a day, just because of payment issues later, you go ahead and give the pneumococcal 23. So that's a combination of giving the two. If you give the Prevnar 20, you're done. We don't give Prevnar 13, not because it doesn't work, but because it was so effective that the strains in 13 just disappeared. And now Prevnar 20 is the next 20 most common strains of pneumococcal disease that we'll see. And who knows, 7 or 8 years, we may have a Prevnar 16 or 26 with new strains. All right, that's Prevnar. Moving on. I mentioned this a few months ago. I'll remind you again so that you don't get ambushed because you forgot. If you have to renew your DEA, you have to do 10 hours of substance use disorder training through an accredited course before you can renew. You can lie, because I just went through this and did my 10 hours training, and I was all ready with my certificate. And when I went to renew my DEA, it was a yes/no question. Did you do this? So, but it's a worthwhile course. I know, Lee, I did one through New England Journal. Lee, who is that you were doing it with?
Well, I haven't. My renewal is a year from now, so I haven't done that yet.
Okay. Well, there was somebody else who was doing one. I know that I saw one available through Journal Watch. There's a lot of places you can do it, but it's a worthwhile course. Okay, Travis, quick question. Do we have any answers on how the medications, what they have in common?
I do not see any answers.
Okay, all right. I'll just, for those of you that got on late, I'll just pose the question again. What do estrogen, so Premarin, antiarrhythmics, and aspirin, all three have in common? All right, we'll move on then. This is a Vivage Beacon thing, but I think it's probably good for all of us. The opiate crisis, just because CMS and the FDA changed their mind and decided we didn't need to have artificial limits on what we could give people, we're just supposed to use good judgment, doesn't mean the problem has gone away. In our facilities, I tell people we don't use PRN opiates for mild pain. So if you have pain, I see it all the time, pain level 1 to 5, give 5 milligrams, and 6 to 10, give 10 milligrams. That 1 to 5, we don't treat that, even 4 to 6. I tell people, unless their pain level is greater than 5, let's not be using opiates. So that's just a reminder. Good, we're covering a lot. Next on the hit list, want to talk a little bit about hospice. And I know we have a number of hospice medical directors here, so your input would be more than welcome along this. Couple things for everybody to understand. We do not, in nursing homes, credential or privilege the hospice providers. So when they come in, they can write recommendations, but they can't really write orders. So all the orders that they write have to go through the primary care provider. So if you see orders you don't like that they put in, it was either you or your group that approved them. You are in charge. Okay, so if you don't like the orders, change them. Couple other things about hospice: we don't use gels, Ativan, Haldol, any other behavior altering gels, because absorption is erratic or unknown. And I've had multiple conversations with the health department that it may be viewed as hiding medications. If you're trying to put Ativan gel on somebody because they won't take it orally, don't want it, maybe hiding medication. So it could be a problem for the facility. PRN antipsychotics come across all the time from hospice as part of standing orders. If somebody truly is in terminal agitation, they're in the last few days, week, 2 weeks maybe, that's fine. But just ongoing, month after month, we just don't want PRN antipsychotics. We know with all the rules that apply to facilities apply whether somebody's on hospice or not. So if there are PRN antipsychotics, those have to be stopped every 2 weeks, new face-to-face visit, new justification documented for why they need it, and then reordered, and then 2 weeks at a time. They used to do that with all psychotropic medications from CMS. They backed off a little bit about a year and a half ago, but at least in the Vivage Beacon facilities, we did not. We see just so much overuse of PRN psychotropic meds. So the PRN Ativans, the sleepers, the whatever it is, every 2 weeks, you need to go in and justify, unless it's PRN benzodiazepines for seizures, that's fine. Short of that and a couple other rare indications, every 2 weeks, you need to justify why it's still necessary. More hospice. I see more and more people that yesterday, yeah, they were going downhill. Today they're on hospice, and all of a sudden they're on PRN morphine every hour. And it's a nice hospice order, and you don't want to miss anything. But theoretically, what that requires is for nurses to evaluate that patient for pain or dyspnea, however it's written, every hour, 24 hours a day. At least be aware of that that's an issue. And if they didn't need anything yesterday, probably 24 times a day, they don't need to be checked today. Maybe, but probably not on every patient. Haldol, one quick note, and Perry, you feel free to jump in here too. It's a fine antipsychotic for hospice to choose, but it has a 20 to 24-hour half-life. There's no reason for routine orders to be given every 4 hours, every 2 hours, every 6 hours. Figure out what they need in a day and just give it to them. Okay, and then the other, just as a Vivage beacon policy, other standing orders that come from hospice, we just don't do it. So the Ativans, the morphines, the hyoscyamin, if they need it, feel free, add it. If they don't need it and no indication for it, don't add it. Okay, feedback or questions on the hospice issues?
This is Mike Tobin.
Hello, Mike.
Hey, good to see you all again. Getting back to your point prior on PRN opiates for 1 to 5 pain or 1 to 6 pain in a hospice patient, sometimes that does make sense because it might be the best choice for their pain, even if it is mild to moderate. Does that sound like a potential option? I just think there's little purpose to suffering at end of life.
No, I don't disagree with you, but as I think about what would give you a pain level of a 1, I ran my hand into the desk. I don't need an opiate, or I stubbed my toe.
So,
and maybe a 3 or a 4, maybe you could stretch it if they really are constantly in pain.
Got it.
That's okay.
Yeah.
But at least have a defined source for the pain or figure out that they have pain. I just get done. I mean, my biggest problem is that it's done too frequently just as a reflex. Let's just put this on.
Fair. Thank you.
Feel free to, by the way, other than Mike, others, feel free to disagree with me.
And Greg, when you're talking about standing orders, you're referring to what they would typically describe as a comfort kit, right? When someone initially admits to hospice and they want to put the Ativan, the morphine on there.
Right.
Okay, so we don't do that.
Yeah, and it was actually one of the other things on my list to cover. One of the other problems with that, I've seen 3 or 4 facilities now get tagged deficiency for not having the consents for psychotropic meds or antipsychotics. Well, because they were in a comfort kit and it was there, but whoever added that didn't go get the consent along with it. I will point out the other thing I was going to say about consents. We do have a standard consent form that you can get access to. If you don't have access to it, ask the social workers, usually keep those. If not, the QI, the quality improvement specialist assigned to the building, should have that. We need to have those signed. And by the way, we need to follow what it says. We ran into a patient about a month ago who everybody knew had signed the form, and actually above their signature at the bottom said, "I do not want any of these," and then signed it. Check no, I do not want any of these. Check no, and then got put on Zyprexa 10 milligrams a day anyway, which would be a big problem for everybody involved. It would, luckily, we stopped it. He didn't have any problems, but the consent forms are there for a reason. Aid in dying, I just wanted to touch on. I sent you the actual legislation from Colorado from the Aid in Dying Act. It's worth your while to read through it one time just to be able to answer questions about it. We don't do it. One of the parts of the act is that every healthcare facility, hospital, nursing home, whatever, has an option whether to participate or not. we categorically do not participate in any facility. We had a serious problem, almost an ethics thing, Lee, in one of our facilities last month with the daughter of a patient who was cognitively intact, but was going downhill. And at any rate, wanted to do the aid in dying thing, went out, actually found 2 physicians to meet the required, had a hospice physician, had a physician and an NP all at the facility, seeing the patient face to face. But the daughter went and found 2 telehealth physicians willing to interview the patient and, write that, no, he's not competent. He can't answer questions. The daughter should take over. And then actually wrote the prescription for the cocktail to kill him, and probably would have followed through if she hadn't mentioned it to one of our nurses that, oh yeah, I'm going to pick up this prescription so we can help dad die. At which point in time we intervened and found she was way out of bounds. The patient actually was cognitively intact, knew what was going on, didn't really want this other than he knew his daughter wanted it. But she took him out AMWay and gave it to him and killed him that night. We called the police before they left. Police came and said, well, nothing we can do. So anyway, we don't, for you guys, it's just a note, we don't do aid in dying in our facilities. The other thing we don't do, we are not allowed, and this came up at ethics this morning, Joe, I feel sorry for Joe on those meetings, but Joe Tansey very nicely stated, we had a patient that really could stand to be restrained, given IM antipsychotics as a almost compassionate order to try to bring him back to some sort of reality so that he could be treated appropriately. We simply can't do that in nursing homes. And I did see it done one time last month in one of our facilities where somebody just ordered IM Haldol, give 10 milligrams, restrain the patient if you need to. And the facility followed through and did it. And we just can't do it. It's an easy way to get an IJ for your facility. And it's just not, even if we'd like to be able to do it, it's not acceptable. The closest thing, and you hate, even with court-ordered meds, we can't give them in the facility because we can't restrain them. I did see in the old days, maybe 5 or 6 years ago, Karen at Uptown, a patient who routinely refused. And once a month, the EMT would show up, the doc from MHCD would show up. They'd take the patient out to the ambulance, give them the injection in the ambulance, and bring him back in. So, I don't know. It's better than send him to the ER, I guess. But we just can't do it. Okay. I only have a couple more things and then we'll open this up for discussion. One of them is about Lidoderm patches. In 2016, the FDA sent letters around to providers saying that Lidoderm patches really didn't work better than placebo and that they were only approved. One of the things in this letter that was really interesting, it was approved for treatment of shingles, but you had to put it in the affected area. And so I don't know how you do that without covering it, but you couldn't cover the vesicle. I mean, it was very bizarre. So basically they said the 5% lidocaine patch is a worthless thing. It's being used in ways that it wasn't approved. And they followed that up 2 weeks later by sending another letter out to insurers, CMS, VA, saying you don't have to pay for Lidoderm patches. Well, the 5% Lidoderm patch isn't cheap, but it's not paid for. If we order it on patients, the facility is obligated to give it to them, so the facility has to pay for it. And so we don't, just as a general rule, if I see those, I try to let everybody know every year, I bring this up, that if I see them, I'm probably just going to discontinue it. Sometimes I'll ask the provider to discontinue it. Otherwise, I'll do it. If you want to use Salon-Paz Aspercreme, the 4% Lidoderm as a placebo patch, feel free, but not the prescription. And then the last thing, Oh, second to last thing, because we still have our trivia question. Iron replacement, we talked about several months ago, that the updated guidelines, one pill every other day is the new guideline. It's more effective than one pill every day with fewer side effects. And one pill every day is more effective than 2 pills or 3 pills every day and fewer side effects. So if you see iron, it's usually because they came in on it. Change it, make it every other day. All right, and with that, in the chat, I'm going to open it up now. They are medicines. I like it. They're on the beers list. Beers list. Jeff Wallace. Okay, Jeff, you came the closest. Those medications, you have to be as old as Jeff and I think, or Lee or Malcolm, to maybe know this answer. In the 1980s, we probably spent 10% of our residency learning how to read EKGs and find those PVCs and figure out class 1, 2, 2A, 2B, 3, and 4 antiarrhythmics. How to make those PVCs disappear was a big part of our training. And it wasn't until the mid-90s when a really bright doc who does no bench research from Mass General said, this is great, we're making the PVCs go away, but if you look at the people that have them and people that don't, we're also killing the patients that get them. So it took about 10, 15 years for people to quit treating PVCs with antiarrhythmics. Estrogen, 80s, 90s, early 2000s, it was the drug of choice for every postmenopausal woman until early 2000s. We figured out, yeah, well, guess what? Heart disease goes up, thrombosis goes up, cancer goes up. Probably not a good choice. Let's get rid of it. At one point in time, Kopic talked about dropping malpractice on any physician that was routinely ordering postmenopausal estrogen. But it took 15 years for people to catch on, for that to really disappear. And now aspirin. 2018 is when the guidelines were updated for women, that it just wasn't good for primary prevention. And about 2 years later decided same thing was true for women, for men, that it isn't good for primary prevention. Not that it doesn't prevent heart attacks or strokes, it just prevents fewer heart attacks and strokes than it causes major GI bleeds. So secondary prevention, it's a fine medication. Primary prevention, it's not. And I just see so many patients that we just leave on aspirin. Feel empowered. You are the physician, the NPPA. You can stop aspirin if it's not appropriate. And it's on the list because this will be the 3rd drug in my lifetime that we thought was cornerstone of everybody needs to be on it. And now we find out, oh, maybe not. Mike, somebody was, no, Dave.
Not all of our people are geriatric and at risk for GI bleeds. If they're in there with MS and risk for heart disease, I think
there are exceptions.
Yeah.
That's fine, but it isn't everybody that comes out of the hospital like they are. And actually, Dave, Dave Shepard's on here. I'm going to let Dave Shepard spend the next minute telling us. Dave did this a year ago. You did. I included all of your references and a few more in the packet that I sent out. So that's that aspirin packet. Do you want to jump in, Dave?
Sure. Yeah. From what I remember, it to put it simply, I just don't think it's useful for primary prevention any longer. And yeah, what was the aspirin trial? And there were a couple of trials in that packet. I don't know if you included them or not, but yeah, it was my understanding that, yeah, especially in the older population, but I don't know that there was an age limit on that.
Okay. We're up against the 1 o'clock time. Jeff, will you do me a favor to get you your prize? Will you put your address in the chat? And then Travis, will you? Oh, good. Travis, you answered. So anybody that, for this one or others that you miss on Journal Club, if you want to get it, Travis just down the chat, put his email address. You can email Travis, and he hates it because people ask me and I say, oh, email Travis. But you can get it from Travis. He'll tell you how to get it. All right. Next, just as a preview, next month, we're going to do a few more things that are just sort of the common things like this, but also really looking forward to Lee is going to present next month. How has it been 5 years since you talked about the Magellan anticholinergic risk scale?
Yeah, 2010, I gave a talk at CHCA, and so it's been quite a while, but I'm happy to include some literature and discussion.
So we're going to talk about anticholinergic meds next month, among other things. And with that, any questions? Covered a lot in a short period of time. Thank you.
Was awesome. Thanks, Craig, and everybody.
Thank you.
Yeah, thank you. And Jeff, I don't see your address there yet. It's going to be hard to get your prize to you. The medical directors can all smile because they know what it is.
Thanks, Dr. Gum.
Thanks, everybody. Have a great month. Oh, thanks, Malcolm. Give it away.
Oh, sorry. I didn't know it was a surprise.
That's okay. Jeff, hey, Jeff, if you're still on, how much longer are you going to be practicing with this? He's off. Okay, I'll find him.
Thanks, everyone.
Jeff is great. Jeff, those of you that know Jeff Wallace, he's wonderful, but he is about to retire.
Oh, really?
Okay. Thanks, everybody. Thanks, Travis, for running it.